So, Namaste and welcome to the Transformation Immersion's mega series on holistic wellness and beyond. I'm your host, Sonal Singhal, a techie turned holistic healer and transformational coach. Joint pain is a common complaint we all have, and it doesn't typically require a hospital visit. But if one suffers from chronic joint pain, then it naturally impacts the quality of one's daily life. So let's hear and learn from an expert who is passionate about reversing degenerative joint disease. I am happy to introduce you all to Dr. Angela Cortal, who is a naturopathic physician based in Oregon. Welcome, Dr. Angela, to the Transformation Immersion, and I look forward to learn a lot from you today, as I myself suffer a lot from joint pains. So,
Well, thank you. Thank you so much for having me, and I'm very excited to be here and yeah, share more about this. So, should I start off with answering any questions, or just kind of dive right
yeah,
in?
I will ask now.
Okay.
Actually, yeah, I'm sure not as you are a naturopathic doctor, and I'm very sure that not many naturopathic doctors are focusing on joint pain. So I wonder what made you take this specialty.
My own joint pain is the short answer. So I went through a long series of, I had an accident and surgery, and it took years and years and years, and I still wasn't healing all that well. And it was my knee, and it really wasn't fully healing and fully sort of cooperating and functioning like how I wanted it to. So as I went through medical school and early on in my practice, I really was just keep on looking, like, what else is there? What else can I do? And I found out that part of the reason for this being such like a big and seemingly complex topic is because there isn't one thing that works well for everybody. There's a lot of reasons behind it. And so that led me to sort of put together more that we'll talk about later, but just sort of how I approach joint pain to try and figure out what is the source for each individual person. And so that led me to really get under control, to improve, and ultimately get really to a new state of joint healing with myself. And so I'm just happy to and passionate about sharing that with my patients as well.
So, doctor, in your case, you met with an injury in an accident.
Yeah.
But what are the other possible causes behind chronic joint pain?
Yeah, that's a good question. So yeah, with mine, I would say that it was potentially the surgery that just accelerated the degeneration. And for me, that was happening in my 20s. For a lot of other people, they're not really noticing maybe any joint pain whatsoever, maybe a tiny bit in their 30s or 40s. And then 50s, 60s, 70s, it's becoming more and more of a common complaint. In the US, about a quarter of the adults have osteoarthritis, which is the most common cause of degenerative joint disease. And so I will say that that's contrasting with other types of arthritis that might be because of an autoimmune condition or an inflammatory condition like rheumatoid arthritis or psoriatic arthritis. So for a lot of my patients, I'm trying to figure out what and where is the degree of their osteoarthritis, is their pain coming from that actual degeneration, and also just getting a clear piece on their particular diagnosis, because not everybody, even if everyone had the same diagnosis, 20 people with knee osteoarthritis, the actual source of where the pain's coming from is going to be different for everybody, just because of our genes and our environment and how we're using our bodies. So that's definitely an individualized approach to figure out where the pain is actually coming from.
So in case of females, we have seen, even if we don't meet with any injury, but, we have seen, like, in my case, I generally during periods time or just before that, I start feeling these pains, particularly in my knees. So do you think, is there a role of hormones there?
Yes, and I am a big cheerleader, a big proponent of the importance of understanding our hormones and how our hormones can impact our joint health. It's a big topic. It's a big source of fascination of mine, and that yeah, I definitely see some patients who through their periods might have a certain part of the month. It's not the same for everybody, but that can certainly be linked. Another big really direct hormonal trigger that I see is for women going through perimenopause, kind of their periods becoming irregular and then stopping. So about that time frame for the next 5 years or so is a major hormonal shift for women. And that can have a really big impact on joint health as well, because our hormones that we call the sex hormones, so estrogen, progesterone, testosterone, all of those are really important for our joint health. People think about them as important for maybe mood or periods or energy, sex drive, some of these other kind of systemic global aspects of health. But for our joints, really specifically, they need enough of those hormones to continue to regenerate themselves and basically become or stay plump, healthy cells instead of kind of dried up unhappy cells that can happen in our joints, in our spine. So a lot of women going through that early postmenopausal time frame. For many women, that'll be the first time they actually get the diagnosis, whether it's degenerative joint disease and even degenerative disc disease. So similar process, but happening in the spine will happen at that time. And there's a very strong correlation to what's going on with the hormones there.
So, in case, whenever we have like any bone related issue, we are approaching an orthopedic doctor for consultation. And what are the typical recommendations from doctors coming from the conventional doctors?
Yeah, so so where I am, I would say so in the US, this is fairly standard. We have the typical approach of called the standard of care. So that's like when someone shows up to the doctor's office, whether that's a primary care or an orthopedic doctor, and they say, my shoulder, my hip, my knee has been bothering me for a long time. They're often told ibuprofen and often recommended physical therapy to help with strengthening the joint and improving the range of motion. And if neither of those are helping or helping sufficiently, helping long enough, then they're often told, well, we're not really sure, so go to orthopedic doctor and see if there's something surgical that can be done. And I guess my big issue with that is that we have a couple of recommendations on the front end, and then suddenly it's a fast track to surgery, where I feel and I see, just based on my experience with myself and patients, that there's a lot else that we can fill in that middle ground, that it doesn't have to be so quick to be considering the surgery. A lot of people don't necessarily need that route or need that route right away, and often we can figure out other reasons for the joint pain and actually address the causes, and not needing to end up going the surgical route.
So as I understand that you have been through a surgery for your injury, and then what are the side effects that you experienced?
I will how I'll describe them is sort of like kind of early and then middle to late. So early, I had a lot of swelling, and in the first couple of weeks, I actually had to get it. There was fluid accumulation in my knee, so I had to get that drained off. I was using crutches and actually a wheelchair for a period of time. I wasn't able to, we'd say, weight bear. I wasn't able to stand on the knee. It couldn't handle just being upright at all. And that eventually sort of resolved itself over a few months. I was doing physical therapy. I was doing all the medications and things that I was being told to being done. I was a pretty young person. I was about 19 at the time when this happened. And then more or less things were like, okay, I went through the course of physical therapy. I was kind of graduated from all of that rehab. But for the next years and really decade plus, I had a lot of weakness and instability. and pain that would come and go. And it would actually usually be higher up. So in my hips and particularly my low back. And the reason that I have for that is just with that weakness in and around my knee, a lot of other muscles were sort of taking over, compensating too much. And so I was getting muscle spasms that were pretty painful in other parts of my body. So that continued. And a weak knee that was sort of prone to just give out on me continued for years, for really from that time around 1920 until I was out of medical school and pretty much experimenting on myself, all the different other approaches that we could be doing. Yeah, so that was about a decade, over a decade later.
So I see you have some alternative options for chronic joint pain. So what is that approach, and how different is your approach from a conventional medicine doctor in treating your patients?
Well, so I approach it like degenerative joint disease or osteoarthritis. We can use the names interchangeably. Is really a complex multi-system condition. We're feeling it in the joints, but where the source of the degeneration is coming from is often multiple and other places. So that's a big difference in terms of my approach. I'm not purely thinking about what can I give you? What pill can I give you that's a painkiller? I think of that as we're just masking the signal, which I've had severe pain. I've had severe muscle pain and joint pain. And I truly understand that sometimes a painkiller just helps someone function, but it doesn't really get them to a different spot. It doesn't change things. It doesn't address the reason for that. So that's the big difference in my approach. And so I think of it as I'm going through in my mind the different aspects that do change my recommendations, my work with patients based on where that joint pain is coming from. And so we touched on one of the first ones that I think about, which is like, what really is the diagnosis? And I don't just mean what the X-ray or the MRI says, but really with the patient's report, with my own physical exam, putting that together to figure out what the actual causes of pain are. Because even if there's a degeneration of cartilage, which is one of the findings of osteoarthritis, maybe their pain is coming from a nerve in the area, or maybe a ligament, maybe a muscle. Like, we can't just jump to assumptions. And so that's kind of an important early phase of the thought process for me. And then I go into all the rest of the things that I basically outlined as a chapter each in my book. And so looking at nutrition, not only adequate levels of nutrition, but also for someone's metabolic needs. Is there certain things that we need to address there so that what they're eating is properly fueling them, but also setting themselves best up for joint regeneration instead of just this constant path of joint degeneration. From there, looking at what they're doing movement-wise, exercise-wise, like just kind of opening it up to kind of lifestyle or functional medicine. Is there certain things in their environment, is there things they're doing that would be more harmful to their joints? And then we already talked about hormones. I'm big at, I have a keen ear for certain types of, so we talked about estrogen, progesterone, testosterone, but also thyroid. That's another big one that I look at, because we know that certain hormonal deficiencies can bring on earlier arthritis and make them worse. So I definitely want to make sure that is addressed if it needs to be for my patients. And then lastly, I think about the things that we can call like the icing on the top, sort of nice things that can be added after the fact when we have that solid foundation of what for each individual person needs to put into place. And that's like supplementation, injection therapies, regenerative injection therapies are fairly well known around where I am. So that's something that patients, I check what they're doing and what they have been doing. If they're taking supplements that are actually proper for them. And we have good research behind some of them out there. But I just want to, again, make sure that we're matching that up appropriately for each person.
You mentioned about regenerative injection therapy. As you
Mhm.
said that you many people are familiar in your place, but I'm not very much familiar with that. Would you like to elaborate on that?
Sure. Yeah, I honestly wasn't sure how common it was,
Mm-hmm.
and so so in the U.S. We have sort of a I would say a regenerative injection therapy is like an umbrella term, and there's certain specific types that fit under that.
Mm-hmm.
In my practice, prolotherapy is the most common one. Another one is platelet-rich plasma injections.
Mm-hmm.
And then also there's other ones that are stem cell, people will call them stem cell injections. Some of them are coming actual from bone marrow
Mm-hmm.
stem cells from that patient. Other ones are coming from amniotic and umbilical, basically like a sterile product that's then injected. So these are injection therapies that are they're kind of similar, but really different to cortisone injections, which is another really common type of injection. So with a cortisone injection, that's like a steroid
Mm-hmm.
medication. It's just trying to get down the inflammation to be basically a pain-killing injection.
Mm-hmm.
Something like prolotherapy, for example, to contrast that, it is going to that area, the area that needs to be sort of healed, that isn't healing, that's
Mm-hmm.
chronically degenerating. But the differences are that I may find with one case of knee osteoarthritis that there's actually a few ligaments in the area that are sort of like the structural scaffolding of the knee, that's where the pain is coming from. So I may be directing the actual injection to different locations,
Mm-hmm.
and that's just whatever each person needs. And the action of it is very different. So with the cortisone just being a anti-inflammatory steroid, like we're just suppressing the inflammation and hoping that helps someone's pain. With the regenerative injection therapies, it's actually providing sort of like a signal to the body. It's tricking it and making it think it's actually just been injured,
Mm-hmm.
and trying to reinitiate the healing cascade. So to
Mm-hmm.
actually get those chronically injured, inflamed tissues to heal.
Mm-hmm.
And so with these therapies, I see when they're well matched up to the right person, the right location, the right type of injection,
Mm-hmm.
that they work well, and patients, when those structures are healed, they're not a concern anymore. So
Mm-hmm.
they're not painful, and that's kind of the goal: get someone back into their life, exercising, whatever it is,
Mm-hmm.
and for those injections really to hold, because it's not something that like the cortisone injections will often wear off and wear off and wear off and need
Mm-hmm.
to be repeated. And with the regenerative injection therapies, we just want those areas to heal so that
Mm-hmm.
someone can go back to their life.
So it's like only one time treatment or what?
Sometimes it's one, sometimes it's a series of treatments. A lot of the research they'll do, gosh, I think somewhere like 3 or 6 at the most, I would say, is
Mm-hmm.
a common number. But yeah, I definitely have some patients where I'm only doing it one time.
Mm-hmm.
It's again just depending on how many structures, and in a knee, that could be 2, that could be 6. There's a
Mm-hmm.
lot of connective tissue area, structures in that area. And so if it's a very mild case, and there's just like one little issue going
Mm-hmm.
on, then yeah, maybe one. In the research where they're looking at like moderate to severe osteoarthritis, and there's a number of structures in the knee that they're treating, that's where they'll often add more treatments. So maybe three or 6, but it's in sort of a course. Like
Mm-hmm.
someone goes and gets the injection, say, every week or every couple of weeks, and then they're kind of done with that set of
Mm-hmm.
treatment.
So it's a short term treatment, but long term benefits, you can say.
Yeah, and I see that with myself and my
Mm-hmm.
patients, and in the research, people, their pain relief holds. They'll check in with them a year or even 2 years later, and it's not wearing off.
Okay, I have this question like about insurance. How much of this is covered by insurance, and if it is not covered at all, then how much does it cost?
Well, so there's a big diversity among, so in the US, and with our like private healthcare insurance, they tend to cover like office visit, evaluations. not every type of practitioner that does these kind of treatments is in network. So now there's an added layer of complexity of in network versus out of network. And as a patient, paying and billing through their insurance, or are they paying the doctor directly? The injection therapies themselves tend not to be covered by insurance. Insurance calls them, experimental, no matter how many decades of research there is. It's just not part of their paradigm. The cost is really variable depending on what exact type of injection therapy we were just talking about. The ones that I do tend to be in the hundreds of dollars. Prolotherapy is less than PRP. That's a little bit more. It's a little bit more extensive and involved of a appointment and procedure and injection. The stem cell ones tend to be on the upper end, a few $1,000s typically, and just depending on the type of treatment, maybe more if someone's getting a very extensive type of treatment. So they really run the gamut. But what would I say on that is just there's information about providers being on the different types of injection therapy organization directories, so someone can look into ones in a certain geographical area, and just kind of look into the different providers, see if they focus on what that person needs to try to find the best fit.
Thank you. So I'm sure you have a lot of clients. So would you mind sharing any of your client success stories with us?
Sure. So some of my favorite recent cases have been chronic SI pain. And so the sacroiliac joint is way down on the back by the kind of the back pockets, and it has sort of a diagonal orientation to it there. And I've had a number of patients, and I've been in the last month reevaluating a few of them, so that's why they're coming to mind, where I would say about 75% of them were women, but some men as well, where they had that chronic pain way down at the bottom, literal bottom, and it would be lasting for years, decades. I had one patient, it came on from a car accident. Another one fell off of a horse. Another one, it started after the birth of her kid, basically through labor and delivery. But this pain and sort of the kind of weakness and wobbliness, the instability of their pelvis just continued for a very long time. And they were given medications that didn't work, and the imaging was focusing on the lumbar spine, so it wasn't showing anything. And so I've just had a number of these chronic sacroiliitis, chronic sacroiliac pain cases where they weren't really discovered and communicated well to patients. And so with everything that we talked about previously, so depending on the patient, whether we were introducing some component of the nutrition, addressing hormones, supplementation, and then the injection therapy, which for the 3 patients I'm thinking of, I did prolotherapy around the ligaments. So what I found, a piece, I would say like a piece of the picture that wasn't brought up to them, not really identified previously, was that those ligaments hadn't fully torn, but they had become unstable, and there was excess motion, inflammation there, and all of that was creating the pain. And so over the course of, with one patient, with all 3 of them, we noticed a really profound effect after the first injection, and then 2 of them we've now done 2 and 3 injections respectively. So with these set of patients, we've just seen phenomenal results, and really a complete reversal of the pain after the first one. And then and then sometimes when they're getting back to exercise, it's getting a little bit achy, just a little bit of pain and instability coming up. So that's why we've been doing the second and third one for those other patients. But yeah, long story short, I love figuring out sources of pain that really just haven't been discovered for patients, because that's where I can help get them to get them out of that place of feeling
Mhm.
stuck and get them to a new place.
You mentioned in your client cases that they started going for exercises and they started having the pain, or they started feeling the pain. So,
Mhm.
do you recommend going for exercises when you are having pain, or first treat the pain and then go for exercise?
That's a good question, because I've seen a lot of recommendations for patients to don't do any exercise. And so I will say, generally speaking, if someone has joint pain, they've been told they have arthritis, I still think it's important to exercise. I just want that to be individualized so that it's not worsening
Mm-hmm.
anything. In the case of the one patient in particular I was thinking of, we've been going through this SI chronic joint pain treatment. And once we did the prolotherapy and the pain went away, she really quickly went back to jogging and running
Mm-hmm.
because that's what she wanted to do.
Mm-hmm.
And ordinarily jogging and running can be great, but that's a lot of movement of the basically the pelvis, and a lot of motion right at those SI joints on the back there. So she just kind of went in too much too fast, which any of us can do. Like, once you're feeling
Mm-hmm.
good, you just want to jump in and do it. You're like,
Mm-hmm.
I'm finally not limited. But going through these types of treatments, I do try to really have an in-depth conversation with patients about what they can get into and what they can do to maintain activity, to not get too
Mm-hmm.
sedentary, but that won't irritate the areas. And so in this kind of a case, it probably just would have been a little bit better to tiptoe into it a little bit more
Mm-hmm.
slowly and do walking instead of, like, the week
Mm-hmm.
after the injection, going on a couple miles jog when that hadn't been done for a while.
Mm-hmm.
But again, we can all get just too excited.
Yeah, it happens. So, doctor, what changes one shall make in their lifestyle to safeguard joint degeneration?
One change, I would say, if anyone who's out there is not doing any type of activity, even if your joints hurt, find something to get yourself mobile, because that sedentary pattern that is easy, and I've in my complicated medical history have gotten stuck in that before, so I do understand on a personal level. You just got to figure out what you can do that is comfortable to get your body rolling, to get it moving, because it's a snowball effect either way.
Mm-hmm.
So if you're sedentary and not moving, that really lessens the amount of nutrition, blood flow, oxygen to those joints. So then that will actually worsen the degeneration, and then your joints are going to hurt more, and then you're going to feel like exercising even less. So it can just go on and on in that direction, versus just whatever you can do to be active, moves all the muscles in that area.
Mm-hmm.
And inside of our joints, we don't have a direct blood supply. There's not vessels, arteries and vessels going into the actual joints. So we need that motion to get what's called passive diffusion, to actually get the nutrition and the oxygen going into those joints. So whatever it is, if it's some really gentle yoga, qigong, I have patients that really love water exercise, and if you have a lot of joints that hurt, that's maybe where you start, because the water exercising, you're working in a lower gravity environment, and so literally whatever it takes, get moving. And for those of you that are thinking, well, this is way too easy, I'm already doing something regularly and my joints still hurt, take a look at what type of exercise it is, because I'm often then transitioning patients from doing something, getting mobile, into building up strength. When we build up more muscular strength, then you're taking more of the load, like in a physics manner, more of the load off of the joints, because the muscles are now doing their fair share. So you get less of that, less of what can happen, which is just excessive banging of one bone on another bone during exercise, if those muscles aren't active and engaged and turn on and basically participating as part of the joint complex that they should be.
So, Dr. Angela, I feel that the niche you have chosen is applicable and relevant to almost everyone. And I hope after listening to this talk, people would like to explore the natural alternative options. For sure. Thank you for coming over and giving us an insight on the work that you do for healing joint pains. I am very happy to inform our viewers that Dr. Angela is giving us a free guide, 7 hidden causes of joint pain. So don't forget to claim it after watching this interview. Thank you for watching us and do share your comment about this talk on my Facebook group, Body, Mind and Soul Healing. Stay connected virtually and be safe. Bye.